David Moipai, and I work with AHN as the Clinical Excellence Manager in Tanzania. So I also work with Dr. Lloyd as well. I'll take this opportunity to welcome all of you to today's Fireside chat. Please feel free to write in the comments or questions section, question and answer section, so that our professor can also respond to those questions. So as he's going on with the presentation, please feel free to do that. For the time being, I would like to introduce to you Dr. Samir Parikh. Is an associate professor of medicine in the Division of Nephrology at Ohio State University. Dr. Parikh received his medical degree from the University of Cincinnati College of Medicine and completed residency and nephrology fellowship at Ohio State. He joined the Ohio State University faculty in 2011, and he specializes in the glomerular diseases with a special focus in the management of lupus nephritis, thrombotic microangiopathy, and monoclonal gammopathy. He is experienced in hypertension, general nephrology, acute renal failure, and chronic kidney disease management. Dr. Parikh's research has focused on uncovering novel biomarkers of disease and optimizing the use of kidney biopsy to inform management decisions in lupus nephritis. He has authored several manuscripts on these topics. Dr. Parikh is and has been the principal investigator on many trials of novel therapeutics for lupus nephritis and other glomerular diseases. Specifically, he was the site PI for both Aurinia phase 1 and phase 2 lupus nephritis studies, and the co-investigator on the BLISS lupus nephritis study. Welcome very much, Dr. Samir Parikh. The floor is yours.
Yeah, thank you very much for that kind introduction, and I'm very happy and feel honored to be invited back to be here with you all again this year. For those that recall, I had the privilege of giving a couple other sessions on lupus nephritis and thrombotic microangiopathy with my previous talks, and for this talk, we'll transition a little bit and still talking about glomerular diseases, but in the setting of bacterial infections, and really discuss the clinical manifestations, management, and outcomes of bacterial infection-related glomerular nephritis. And this has actually been a point of interest and a topic that's been discussed heavily, most recently at our American Society of Nephrology Kidney Week this past November. We had an entire session on infections and glomerular disease. And so I thought it was the right time to kind of talk about this topic. And I'm very curious to hear your all feedback about your own experiences about this. Now, the way I've outlined this talk is we're going to talk a little bit about post-infectious, and we'll talk about peri-infectious glomerular diseases, and we'll do it through the lens of a few cases to just highlight some examples. All right, you can see my disclosures here. Nothing relevant to this talk. And so let's start with an introduction. So, if we go back to 1812, when C.D. Wells kind of first described a case of, red urine and bubbles or, in the urine, and really kind of described the first case of scarlet fever, acute post-streptococcal glomerular nephritis. That was the description of it back in 1812. And really over the decades and centuries to follow, acute post-streptococcal glomerular nephritis became kind of the poster child for glomerular diseases. It's how we kind of defined and understood acute nephritis. Sorry, here, 1 second. Let me just move this to the bottom. Acute nephritis, and it's now well characterized in the literature. And so we've had progress in our understanding of its mechanisms and management. But acute glomerular nephritis in the setting of an active infection, so this is not post-streptococcal glomerular nephritis, and we'll talk a little bit about the differences, but something that's happening in the setting of an active infection was actually initially described in the early 1900s as well. But really there was a dearth of reporting on this until really the past 2 decades. And over the past 2 decades, there's been a large number of observational cohorts and studies looking at the acute glomerulonephritis in the setting of an active infection. And one of the major questions that comes up is, how is it different? How is it different than post-streptococcal glomerulonephritis? What's pathogenically, mechanistically, management-wise, what do we do differently? And we're going to talk a little bit about that. So an understanding of the pathogenesis, management, and outcomes of glomerulonephritis associated with active infection so far has been limited, but it's certainly lagging acute post-streptococcal glomerulonephritis, but it's growing, and the body of literature is growing, and I'm going to go over some of that. Additionally, there's a lot of pitfalls when we think about this diagnosis, and hopefully we kind of highlight those through the cases. So first, let's talk about post-streptococcal glomerulonephritis. This is, really been well reported on, and one of the really nice articles to review was by Rodriguez, Iturbe, and Jason in 2018. And then we have a review with me and my colleague and I, Dr. Satosker and I here at Ohio State in 2020, Nature Reviews Nephrology, talking about all aspects of bacterial infection and glomerulonephritis. And so, post-streptococcal glomerulonephritis is still the most common cause of acute GN in children, but it does have some discrepancy in its epidemiology worldwide. The major culprit is group A streptococcus infections, but also group C and G have been implicated in certain areas in epidemics. Approximately about 470,000 new cases annually. But what you can see here by this world map is this difference in case number. This is per 100,000 person years, and these are obtained from biopsy studies and population calculations in different countries based on the country present. So if you see the case numbers are high in places like India, in Aboriginal Australians in Australia, Tunisia, reportedly in the Middle East, in Jordan and Saudi Arabia, and in South America, in Brazil and Chile. But then if you look in other countries such as Italy and France and the United States, the case rates have actually decreased significantly over the past several decades. And in fact, post-streptococcal glomerulonephritis is not a very common entity in the United States, at least. It is still seen periodically in pediatric population. Maybe it's rarely seen in the elderly population, but it's still become a more uncommon entity. But worldwide, a lot of it seems to depend on whether we are discussing a developing country or a country more developed. And some of the reasons for the decrease in incidence and prevalence is related to fluorination of water, earlier recognition of disease, and antibiotic therapy. But how does post-streptococcal glomerulonephritis present? So, the typical learning, and this holds true, is you get an acute infection with beta hemolytic strep infection. And then you get this infectious period, and then you get this latent period that goes on for 1 to 4 weeks. And after that, you get this acute glomerulonephritis. So this is key in terms of the difference when we're trying to differentiate one form of infection-related GN from another, is that the infection here is cleared. In post-streptococcal glomerulonephritis, you have this latent period where an acute GN develops afterwards, but it's after the infection has resolved. And the clinical presentation can be anything from asymptomatic glomerular hematuria to severe nephritis with acute kidney injury, hypertension, and edema. Clinically, you'll see a low serum C3 and CH50 within 1 week of disease onset. And pathogenically, there's 2 culprits that have been identified. The NAPLR and pyrogenic endotoxin B have both been suspected to be pathogenic players in driving acute post-streptococcal glomerulonephritis. There's more evidence with SPEB. NAPLR, there was one study that showed it to be overexpressed or upregulated in the urine and blood, and also found in the kidney in patients with acute post-streptococcal glomerulonephritis, but that study was not replicated in another study from Switzerland, did not have the same findings, whereas the SPEB antigen was found in the kidney, co-localizing with complements in acute post-streptococcal glomerulonephritis in 2 to 3 different studies, suggesting that this may be the more pathogenic variant. When we look at the autoantibodies, everyone talks about the anti-streptolysin antibody, the ASO titer. And then we talk about low serum C3 or complement activation. And what you can see, and this is a nice figure from Hunt and colleagues in 2019 that kind of outlines the trajectory of all of this stuff. So at the onset of infection, you can see time 0 here, low C3 occurs pretty quickly. So C3 drops and the nadir's around 1 to 1.5 weeks after the infection develops. But the ASO titer also goes up pretty quickly within the first week of infection, but it stays up for a long period of time, whereas C3 kind of recovers after 3 to 4 weeks. The ASO can stay up for weeks and weeks and weeks after the infection resolves. So whether you can actually use it to help understand the tempo of disease or where in the nature of the disease you are, it's unclear. And in fact, it also is a little bit more specific for certain infections. So ASO is good for pharyngitis, but it's not good for a skin infection. So in someone who has a skin infection and develops post-streptococcal glomerulonephritis, the ASO titer is not helpful. In fact, the anti-DNase B titer is probably the better autoantibody to look at, because that's present in both pharyngitis and skin. And it's positive in about 80% of skin cases and also positive on 95% of pharyngitis cases, whereas ASO is specific to pharyngitis. So the best test, if you can get it, is a strepsizine test, which is which actually checks all 5 antibodies for nephrogenic strep antigens, including ASO, anti-double-stranded DNase B, anti-NAD, ASKase, and AHase antibodies. But that's not always readily available. In fact, even in our own institution, we don't get it readily. We usually do the ASO and anti-DNase B antibody when we're considering acute post-streptococcal glomerulonephritis in those cases. So, but just kind of so you kind of understand the tempo of disease. So you can see the C3 starts to recover. And remember, acute post-streptococcal glomerulonephritis is typically a self-limiting disease. So you expect the complement activation to kind of subside, C3 to normalize. ASO, you want it when you get it, if it's elevated, it may suggest that there was an infection, but tempo and timing of infection you may not be able to interpret as well. So when we think about treatment of acute post-streptococcal glomerulonephritis, it's largely supported, right? There's been a number of trials. A lot of these are really old studies that looked at acute post-streptococcal glomerulonephritis and the treatment of which, both looking at antibiotic therapy as well as supportive therapy with blood pressure control, diuretics, etc. And then one particular therapy looked at treatment of, and this is looking at severe, this is the one that's highlighted at the bottom. It looked at crescentic glomerulonephritis due to acute post-streptococcal glomerulonephritis. And really the question here was, if someone had such severe inflammation, crescentic GN, rapidly progressive glomerulonephritis due to strep infection, would immunosuppression be beneficial? Would it help improve outcome and preserve kidney health? And you could see the treatment was either the B, supportive care, or A, they got steroids, azathioprine, cyclophosphamide, antiplatelet agent, heparin, and so anticoagulation. And this study was done in 1981, so you can see how long ago this was done. And what they found was the outcomes were exactly the same. As a self-limited disease, patients' kidney function, their residual kidney function was similar whether they got immunosuppressive medicine or not. If anything, the patients in the immunosuppressive arm actually had a faster resolution or improvement in their kidney parameters. But at the end of the follow-up period, everyone kind of, the patients in the supportive arm or the immunosuppressive arm did equally well, suggesting that really this is a condition where supportive therapy is the name of the game. And maybe you could consider using something like corticosteroids in patients who have the most severe forms of this condition, the crescentic rapidly progressive glomerulonephritis. But there's really no strong evidence to suggest that improves outcomes any different than just waiting it out and providing supportive care. I hope that all makes sense. Any questions? Again, if there's any questions throughout this, feel free to stop me or post something in the chat. I'm happy to answer them as I go. So the other thing to think about, though, in this condition is that, say that this condition goes on. So the disease persists after 8 to 12 weeks. At that point, you really want to start thinking about, hey, I don't know that I got this I don't know that this is really post-streptococcal glomerulonephritis. This could be something else. This post-streptococcal glomerulonephritis should resolve itself certainly within 2 months' time. And if it's still lingering, then really there's a lot of disease mimics that we need to consider. And at that point, really should be considering kidney biopsy. Because, generally speaking, in the pediatric population, where the approach is to treat supportively, generally not undergo kidney biopsy. In the older population, adult population, maybe you go to kidney biopsy a little bit quicker because you're not exactly sure what you're dealing with. But if you haven't performed a kidney biopsy, the disease is lingering, then this is when you'd want to consider a kidney biopsy to obtain a definitive diagnosis, because you may be dealing with a mimicker, could be IgA, could be C3, glomerular nephritis, etc. What about the prognosis? So we talked about how treatment is largely supportive. So this is looking at 2 different populations. So the top table shows in 4 different studies is looking at the pediatric population. You can see here in multiple different countries, USA, Trinidad, UK, Australia. You can see the years where these studies were done, anywhere from 1964 in the US to 2012 in Australia, the number of patients, and the years of follow-up. So these are nice studies with long-term follow-up, 10, 15 years. And what you can see is really excellent outcomes across the board. Proteinuria, residual proteinuria, and a generally low percentage of population and low percentage of patients. In the one study, the Aboriginal children, where they had high percentage of residual proteinuria after greater than 10 years of follow-up, these patients had actually repeated episodes of post-infection infectious glomerulonephritis. So they got strep, they got post-infectious glomerulonephritis, strep glomerulonephritis, resolved, and then it got it again. And so that may explain why they had more residual proteinuria and hematuria in this population versus these other populations where patients largely did well with long-term follow-up. And that holds true with what we understand, or what we know about acute post-streptococcal glomerulonephritis in the pediatric population. So overall, their prognosis is generally excellent, 1% mortality, 2% ESRD risk. What about the adult population? There's not as much data here in the ESRD population. But here are 3 studies looking at this. The sample sizes are relatively low, 24, 57, 56 patients in multiple different countries, older studies in general, with reasonable follow-up again. And what you find, though, is that the outcomes are variable. More residual proteinuria, hypertension, CKD, at least in 2 studies, about 50% of the patients had residual CKD. So the prognosis in adults, as far as we can understand, may not be as good. 30 to 50% of elderly patients with post-streptococcal glomerulonephritis are left with persistent hypertension, proteinuria, and residual CKD. Of course, there's a lot of potential explanations for this. I think probably the one that stands out the most is, the older population has more comorbidities, less residual kidney health, etc. Those who are getting post-streptococcal glomerulonephritis may not be, in the adult population, may not be the healthiest population. Obviously, there's confounders with diabetes. So all of these may be contributing to these poorer outcomes in that population. But now let's take a step back. So that's acute post-streptococcal glomerulonephritis. I think that's pretty well understood by nephrologists. It's something we learn about in medical school. We talk about, acute post-streptococcal glomerulonephritis all the time as we learn through training, because it's a poster child of development of nephritis. That's when the first nephritis was, described. But there's acute post-streptococcal glomerulonephritis, but then there's also infection-related glomerulonephritis, and that's I want to spend a second just differentiating these 2 entities. So acute post-streptococcal glomerulonephritis, we talked about how the time course is 1 to 4 weeks after the infection has resolved. Most commonly occurs in children. We're talking about pharyngeal infections, skin infections with strep, and the natural history is such that it resolves after several weeks. With maybe you have some minor glomerular abnormalities that persist, but it usually resolves and patients do okay. Your histology is typically with focal diffuse proliferative glomerulonephritis, heavy C3 staining, maybe some co-staining or even milder IgG staining. And you have that classic subepithelial humps on electron microscopy. Their overall prognosis is good. On the flip side, and this is where we're going to spend the rest of this discussion, we're going to focus on infection-related glomerulonephritis. So infection-related glomerulonephritis occurs in the setting of an active infection. This is typically a subacute chronic infection. The glomerulonephritis occurs weeks to months after the infection starts, but the infection has not resolved. Most commonly affects adults with chronic illness, such as diabetes, alcoholism, or those with immunosuppressed status. We're talking about deep infections here. And like I said, the GN does not resolve until the infection really resolves. And the biopsy can have some overlap with post-streptococcal glomerulonephritis. You may see some subepithelial humps, but they're not always present. There is heavy C3 staining, just like you see in acute post-streptococcal glomerulonephritis. Serum C3 may be low in about 30 to 50% of cases, but it doesn't have to be. But you can get a very proliferative immune complex glomerulonephritis, neutrophil dominant, depending on the pathogen. It could be IgA dominant or IgA C3 codominant, and we'll talk about that. And then the prognosis is more variable. And of course, this occurs more commonly in the adult population. So let's talk about the pathogenesis of bacterial infection-related glomerulonephritis and post-streptococcal glomerulonephritis. And this is all putative understanding. So you have nephritogenic bacterial antigens, right, that are released from the bacteria. So that maybe that's the SPEB that we talked about with strep. But maybe there's some super antigens, staphylococcal P70 has been described and found in the kidney of patients with staph-associated glomerulonephritis. And there's unknown antigens for gram-negatives. This and that in turn leads to deposition. So, and then the idea here is either you're getting deposition of circulating bacterial antigen, immune complex antibodies in the kidney, particularly in the mesangium, versus in situ bacterial antigen antibody immune complex development in the glomerulus, or, and perhaps more likely, you get the in situ localization of the bacterial antigen without immunoglobulin, and that triggers an immune response. And that immune response is typically neutrophil driven, but then you get complement activation, leukocyte recruitment, and then cytokine release and proliferation. And I'll tell you, when you look at the biopsies of patients with infection-related GN, it often is very profound, the level of inflammation that's present within the kidney. So what drives this, and why do some people get and others don't? It's unclear. Perhaps there's some host factors, genetic susceptibility, or abnormalities in the alternative complement pathway, but these are all just hypotheses that need further study. The presentation on biopsy can range from mesangial involvement only to mesangial endothelial involvement, leading to proliferative inflammatory glomerulonephritis. So let's move on to the first case. So this is a 51-year-old, and all of these cases are patients that I saw on service in the hospital. So this first one's a 51-year-old male with a history of hypertension, longstanding type 2 diabetes, who presents with skin rash involving his upper arms, abdomen, flank, and lower extremities, right wrist pain and swelling that's been present for several weeks. It reports low-grade fever and more difficult to control blood pressure recently. His past medical history, as I mentioned, hypertension and diabetes. He's a construction worker. He takes amlodipine and metoprolol, and he's got allergies to codeine. This is what his skin looks like on presentation. So pretty considerable lesions on his legs. They're also present on his trunk and his upper extremities. So dermatology is consulted. He undergoes a skin biopsy, and his skin biopsy shows leukocytoclastic vasculitis with some positive C3 staining in the vessel. So this kind of clinical scenario, leukocytoclastic vasculitis, he's got this terrible looking purpuric rashes, bullous rash on his extremities, and he's got this positive C3 with leukocytoclastic vasculitis, make you worry about small vessel vasculitis, makes you worry about perhaps even an IgA vasculitis. So let's take this and look. So let's look at his kidney function over the course of his presentation. So on day one, he actually had pretty normal-ish kidney function. So here we're talking about this levels of creatinine 1 milligram per deciliter. So pretty normal until about day 4. And at day 4, his kidney function starts to worsen, gets closer to 2 milligrams per deciliter here by day 10. So his urinalysis shows large blood, 100 protein, greater than 20 RBCs per high power field, greater than 20 white blood cells per high power field. On his urine microscopy, so we're called to evaluate the patient. He's got acanthocytes, positive white blood cells, granular casts on his biopsy, or on his urine sediment. And so we say, okay, he needs a biopsy. And at this point, it's unclear what his diagnosis is, though the working diagnosis is IgA vasculitis or HSP. So he undergoes kidney biopsy, and the kidney biopsy shows a proliferative glomerulonephritis. You can see here with focal crescent formation, if you can see my cursor here. And then the tubular interstitium shows pretty profound acute tubular necrosis. He's got very strong IgA staining, and glomerular IgA, mesangial IgA staining in his glomerulus, as well as codominant and very strong C3 staining. And you can kind of see the immune complex deposition here on electron microscopy. So when we take a pause and we think about this presentation kind of fits with an IgA vasculitis and what you would typically see from HSP. And the presentation is pretty consistent with that too, other than maybe the patient's age. And so when we look at the potential pathologies that infection-related GN can mimic, IgA nephropathy is certainly high on that list, and staphylococcal infection-associated GN causes an endocapillary hypercellularity that it can be significantly more than what you see in IgA nephropathy. But the challenges for the pathologist is on biopsy, you see IgA staining, just like we showed you on that biopsy, and you see C3 staining. So it's hard to say sometimes whether this is an IgA nephropathy that we're dealing with, or is it an infection-related GN. And certainly in HSP, or IgA vasculitis, as we call it now, you can get a very similar presentation on biopsy with strong IgA, moderate C3 staining. And what you shouldn't see is these subepithelial humps that you can see in infection-related GN. So just kind of to highlight that the pathology alone may not give you the answer. The history may tell you more, while the pathology gives you kind of what's present in the kidney. It may not tell you what's driving that injury, and that's important because it may really impact how you treat the patient. So the diagnostic pitfalls of someone who's got a staphylococcal infection-associated glomerulonephritis or an infection-related glomerulonephritis of any site, as we mentioned, is you can get glomerular IgA deposits, right? And that you can see in IgA nephropathy. You can get this vasculitis-like rash. That's what you see in IgA vasculitis or even ANCA vasculitis, as this patient has. The subepithelial humps may not be seen on electron microscopy. So subepithelial humps are classic for post-infectious glomerulonephritis, but we may not see that in infection-related GN. And you can get crescentic and necrotizing lesions on biopsy that mimics other forms of GN. So why am I bringing all this up? So at the time that we saw this patient, and we go back to case 1, the patient had a working diagnosis of IgA vasculitis and had been started on high-dose steroids. And his symptoms continued to worsen. His kidney function worsened, his rash worsened despite the steroid. This is a timeline of his presentation. So 6 weeks prior to his presentation, he developed acute right wrist pain. He was given a 5-day course of steroids. Didn't get much better, saw an orthopedist, and had an MRI of his wrist and was diagnosed with tenosynovitis. At this 3-week time point, he received a steroid injection. Now, 4 days prior to presentation, he develops this rash in the lower extremities with pinpoint lesions, and that progresses. 2 days prior, the rash continues to spread to his upper extremities. He develops abdominal pain. And this right wrist pain starts to develop again. Now, at midday, he's got this rash all over the place. He's got right wrist pain and swelling. He's got negative blood cultures, negative autoimmune disease workup, and his serum creatinine starts to rise. So that's his kind of presentation, and I highlight this because this is not an atypical presentation for someone with infection-related glomerulonephritis. So how do I know this patient has an infection? He undergoes an MRI of his right wrist, and that shows osteomyelitis, and that bone culture comes back positive with MRSA. So this entire course and all the pictures I showed you is consistent with the staph-associated glomerulonephritis, not IgA vasculitis. We come out with this diagnosis, we tell them to back off the steroids, and we treat him supportively with antibiotics. All right, so I talked about some of the diagnostic pitfalls of infection-related GN, and here's a table that kind of highlights the differences between IgA vasculitis and staph-associated GN. This is specifically staph I bring up because that IgA C3 deposition that we're seeing in the kidney is what you see with staphylococcal infection-associated glomerulonephritis. So you can see the difference between IgA vasculitis or HSP and IgA-like staph GN, the difference in age, mostly children versus elderly population, the comorbidities, diabetes, particular diabetes, alcoholism, endocarditis, recurrent catheterizations, malignancy. The infection triggers. So IgA may be triggered by a recent upper respiratory tract infection, sinus infection. A couple days later, you develop that IgA flare. Meanwhile, a staph-associated GN, you get an active infection, maybe undiagnosed actually prior to the AKI. I can only tell you how many times we've seen that, where we get a biopsy in a middle-aged male with diabetes. It shows IgA C3, very proliferative, acute. We don't think it's IgA vasculitis, IgA nephropathy. It could be, but it looked a little bit too inflammatory, too many neutrophils. And you find that they have a tooth infection, a tooth abscess, a dental abscess that's been there for a long time that triggered this whole thing. Or they have endocarditis that was undiagnosed. So these are things that to look for, and just because you see the IgA C3, don't be satisfied this is IgA nephropathy, especially if the rest of the pattern doesn't fit. Skin biopsies can be nonspecific and show the leukocytoclastic vasculitis in both cases. The kidney biopsy otherwise can show a fairly similar presentation. You may get more neutrophil dominance in the staph GN and more dominant C3 staining. And the treatments are very different, right? So in IgA staph, like staph GN, you're going to treat the infection. There's no role for steroids, and we'll talk about that. Meanwhile, in the other case, it's supportive. Steroids are considered in severe cases, has a self-limited and favorable outcome versus variable to poor kidney outcomes with infection-related GN. And I mentioned, how do we differentiate infection-related GN from other forms of glomerulonephritis? Time course matters. This is where history is important. When did all this start? Staphylococcal-related GN occurs weeks after the infection started. Whereas IgA, C3, a few days, we're talking about post-streptococcal, we're talking about 1 to a few weeks after the infection is resolved. And then you have other forms of de novo GN usually take weeks to months before they present. How do these patients present? Oftentimes they present with severe kidney injury. This is a compilation of clinical presentation, data of clinical presentation across 4 studies. You can see the references here. And the average serum creatinine at presentation across these 4 studies was 4 to 5 milligrams per deciliter. So pretty advanced acute kidney injury. Almost 40% of patients require dialysis at the time of diagnosis. Almost everyone has hematuria, microhematuria, and a vast majority of them have nephrotic range proteinuria, with the average proteinuria about 3.5 to 5 grams across the studies. So this, you can see how in these patients with infection-related GN across these 4 studies are presenting very severely. Their C3 is often low. The C4 may be low in some cases, but in lower percentage. About 20% will have a purpuric rash, and blood cultures will be positive in only 50% of cases. Now, those are 4 studies, and these are observational cohorts, smaller numbers of patients. But then in the largest study, this was a study done recently in 2021 from India, where they had in a cohort of 501 patients, and they divided them into 3 groups, actually, para-infectious GN, which would be your infection-related GN patients. So this is where the infection is active. Post-infectious GN. And then they had this peri-infectious, where it was hard to tell the infection. This was the GN developed within 1 to 7 days of after the infection resolved. So it's hard to say whether it's post or peri-infectious. But you can see the presentation in patients who had a para-infectious GN or infection-related GN was more severe actually than those with post-infectious GN, with the average 24-hour urine about 4 grams per day, serum creatinine of 3 milligrams per deciliter with a CKD-EPI eGFR of 18 mLs per minute, relative to 34 mLs per minute in the post-infectious group. About 76% of these patients had a low C3, similar to the post-infectious group. And you can see the sites of infections across the cohort, urinary tract infections, and as well as lung and skin and upper respiratory tract infections across the group. The difference here is in the post-streptococcal and in the peri-infectious group, the only small percentage actually had streptococcal infection. Many had other forms of bacterial infections. And we'll talk a little bit more about treatment in this study as we go down through the course of the talk. So who's at risk for infection-related glomerulonephritis? The exact incidence and prevalence is unknown because we're lacking large studies, although this most recent study from India may provide some clues. Staph, or MRSA, is certainly the leading cause of nosocomial infections in the USA. I'd be interested to hear how that's like in your respective countries. It represents about 44% of cases. In several cohorts, staph-associated GN represent about 0.1 to 0.9% of kidney biopsies, but these are individual smaller cohorts. The true incidence, though, may be much more than this because, you know, a large part of the times, at least in the US, when patients are diagnosed with acute kidney injury, we're quick to call it ATN. Biopsies are often deferred, and we manage these patients clinically. They come in with an infection. We say they have acute kidney injury. It's probably ATN from the infection, sepsis, whatever it might be. And further evaluation to see if they actually have acute glomerulonephritis due to the infection is not necessarily always pursued. So when we think about who's at risk, and these are across 3 studies, predominantly done in the US here, a Caucasian predominance, males, and then those with underlying diabetes. And this was kind of the biggest risk factor here is patients who have comorbidities, diabetes, alcoholism, malignancy. These patients are in particular risk. And they're the patients who are at risk for these infections. and deep-seated infections that can brew for a period of time that allows for the right milieu for them to develop this glomerular nephritis. So great question. I got a question in the chat about CRP, procalcitonin in case 1. The osteomyelitis was of the right wrist, and staph was found in bone culture, but the blood culture was negative. Staph was actually found in the bone culture. Procalcitonin, so that case is from 2011, so that predates procalcitonin as a measure. CRP was absolutely elevated, and so was ESR. So non-specific clues of inflammation, but certainly at those levels, you'd certainly worry about infection. But good point, and those are other markers that we certainly want to use when we're concerned in trying to differentiate infection from other potential causes. All right, so what kinds of infections are we talking about when we're talking about infection-associated glomerulonephritis? So the predominant ones are the gram-positive staph and strep, and you can see the different types of staph infections that could be contributing. But also there's a whole laundry list of gram-negative infections that have been implicated in infection-associated glomerulonephritis. And where are these infections? They're all over the place, but the one I wanted to highlight most commonly and most concerning is endocarditis. And while, when we think about endocarditis, we think about a patient comes in with recurrent positive, blood cultures, clear evidence of heart failure, and they have a big vegetation on their heart valve. But I'll tell you, we've diagnosed infection-related glomerulonephritis and backtracked and found endocarditis in many cases in the hospital where we had to convince people to do TEEs to evaluate for endocarditis, where surface echoes were negative. And patients, we did the kidney biopsy, we show a certain pattern, we're worried that this could be infectious, and they do the TEE and they find a vegetation on the heart valve, and likelihood that was a trigger. So just to let you know that, kind of suggests that just because it's not obvious, if the biopsy findings are suggestive, make sure we're doing a thorough dig to look for these deep-seated infections. It may not be endocarditis, it might be an abscess. It could be a dental abscess, as I mentioned. Obviously, skin ulcers, skin infections, pneumonia, all of these things have been implicated. Osteomyelitis, as we mentioned, have all been implicated in infection-related glomerulonephritis. Sorry, for some reason, my slides are moving a little bit slowly. All right, so let's move to case 2. So this is a 56-year-old male with a history of type 2 diabetes and an aortic valve replacement. He's admitted with altered mental status, fever, shortness of breath, and acute kidney injury. Serum creatinine is 4.5 milligrams per deciliter. Patient's found to have nephritic urine sediment. A serologic workup shows PR3 positive, MPO positive ANCA, positive ANA. The TEE reveals an aortic valve vegetation. Blood cultures are positive for MRSA. Patient undergoes a kidney biopsy, and the kidney biopsy shows this pauciimmune crescentic glomerulonephritis. So you can see the crescents here on staining. A paucity of immune deposits, C3 is present, very few immune deposits on an electron microscopy. So this is concerning, right? This is a very aggressive vasculitis. It almost looks like ANCA-associated vasculitis based on the biopsy. But then you have this clinical picture where this patient has this vegetation on a heart valve, has blood cultures positive for MRSA. And so indeed, ANCA positivity is not uncommon in infection-related glomerulonephritis. And I'll highlight this here. This is looking at ANCA serologies in patients who have ANCA-associated or pauciimmune glomerulonephritis. You can see you can have MPO, PR3. Very uncommon to have both MPO and PR3. Whereas in infection-related glomerulonephritis, you can have a pauciimmune glomerulonephritis, at least in one study, it was up to 47% of cases, it can be pauciimmune. Maybe you'll see some electron deposits, maybe you'll see some epithelial humps, crescents are present. And you can have both MPO and PR3 in up to 20% of cases. You can also have other autoantibodies, such as ANA, anti-SSA, anti-cardiolipin antibodies, type 3 cryoglobulins. So the point is that we shouldn't be fooled here. Sometimes these patients can present as the case that I mentioned, but sometimes it'll be more subtle, and it won't be so obvious that this patient has signs of infection. And oftentimes we'll reach for the steroids, and maybe that's not the wrong thing to do. Maybe we do reach for the steroids. But we got to continue the workup, especially if you have to maintain a high index of clinical suspicion for infection and make sure we ruled that out before proceeding with more aggressive forms of immunosuppression. So this patient was treated with antibiotics. Patients with infection-related GN due to pauciimmune GN, that have a pauciimmune GN on biopsy, they're treated with antibiotics. Steroids and immunosuppression are often used in these cases. but outcomes are poor and the benefits are still unclear. There's some suggestion that maybe plasma exchange or IVIG can be considered, but we don't have any data to support those approaches to treatment. And in fact, since this is still relatively rare, since it's still kind of a condition that's becoming more and more recognized, hopefully we'll have better understanding of how to approach these patients in the future. But at present, largely the standard of care is supportive. Treat them supportively, treat the edema, the hypertension, the renal failure, and treat them with antibiotics and hope for improved outcomes with time. Let's move on to case 3. So this is a 36-year-old male with a history of atrial septal defect, SAS post-closure, congenital pulmonic stenosis, SAS post-valve replacement, AV-NRT, SAS post-ablation, ventricular tachycardia, SAS post-ICD placement. So he's got a whole bunch of foreign material in his heart, around his heart. Was referred to the hospital for acute kidney injury and gross hematuria. Additionally, he complained of fever and night sweats times 1 month. His lab showed creatinine of 3.3, increase from baseline of 0.8, large blood and protein in his urine, numerous acanthocytes, red blood cell counts. His proteinuria is about 4 grams. He's got a positive ANA, positive rheumatoid factor. His PR3 is positive, but he's got a low C3 and low C4. And his kidney biopsy shows this. It shows a full house pattern of immunofluorescence: IgM positive, IgG positive, IgA positive, C1q positive, kappa lambda C3 positive. So he's got this proliferative immune complex glomerulonephritis, fibrillary necrosis, crescent formation, full house pattern, and really suggestive of lupus nephritis. So this patient's preliminary diagnosis was he's got proliferative lupus nephritis, class 4. He started on high-dose steroids and mycophenolate, mofetil. Obviously, this talk is not about lupus nephritis, so I'm going to tell you he doesn't have lupus nephritis. So further history. This patient mentions that he had a cat scratch about 3 months prior to presentation. We decided to work this up further, and he has serologies that are positive for Bartonella-Hensley, IgM greater than 120, IgG 1 to 32,768. So interestingly, and I've had 3 cases of this over the past year, and there's actually a rise in Bartonella, at least in the US. And so not surprising to see this, but Bartonella infection can cause a culture-negative endocarditis. And in fact, it's one of the more prominent causes of endocarditis, at least in the United States. It can be a great mimic, similar to this polyimmune that we saw in the last case. It can be a great mimic of autoimmune disease. And in fact, 35% of cases with Bartonella-Hensley mimicking glomerulonephritis are positive PR3 ANCA. And 77% of patients, with Bartonella endocarditis will have ANCA positivity. So this is a study looking at endocarditis associated with glomerulonephritis. I'm going to tell you actually one last thing about Bartonella. In all 3 cases that I saw over the past year, all of them had this full house pattern of immunofluorescence and mimicked lupus. And our initial consults were, hey, we think this patient has lupus nephritis, positive ANA, low C3, C4, coming in with vague symptoms. And in all 3 cases, they had Bartonella-Hensley infections. So in this study of 48 patients with bacterial endocarditis, this was done by Boyles and reported in 2015. They had biopsy-confirmed glomerulonephritis. 78% were male, 53% were due to staph infection, but 8% of them were due to Bartonella infection. And the valves involved include tricuspid aortic and mitral valve, and polyimmune glomerulonephritis was the most common finding. So I mentioned I'm seeing full house pattern, but this is also another prominent finding, polyimmune GN, especially in endocarditis associated glomerulonephritis. So whether it's staph or strep associated endocarditis associated glomerulonephritis or Bartonella, you have to think about polyimmune glomerulonephritis and think about full house pattern. And finally, just really think about it as a great mimic. Think about infection similar to malignancy as a great mimic of our autoimmune diseases. And you can see the clinical presentations here. About 29% had positive ANCA, 53% had crescentic GN. And IF was positive for IgG in only 30% of cases, with acute tubular injury present in 86%. So just because you see granular casts, that doesn't mean that these patients don't have an underlying glomerulonephritis going on at the same time. So I'm going to finish up by talking about the approach to treatment. Bottom line is you got to treat the infection, right? So treat the infection, treat the infection, treat the infection. This is the general approach to treatment of infection-related GN. The infection's active. We need to eradicate it. If we don't eradicate it, it doesn't matter what else we really do. Culture-driven antimicrobial therapy appropriately dosed for kidney function should be given as soon as possible. In cases where possible, a surgical approach may be needed to eradicate the infection. I'm thinking about endocarditis. And then otherwise, our treatment is largely supportive: blood pressure control, volume management, medical therapy for electrolyte disturbances. Perhaps we can use RAS blockade if our GFR is stable, and dialysis for progressive failure. The real question that comes up all the time is, what do we do with immunosuppression? Should we immunosuppress these patients because they have this proliferative, very aggressive form of glomerulonephritis? Will that help improve outcomes? Now, most of the data are from, retrospective observational studies where steroids were used, and here's a list of them. We published this back in 2017, kind of this table, looking at multiple different studies, small numbers of patients. You can kind of see here, mixed population of bacteria, mostly staph though, and then these patients getting corticosteroids. And you can see renal recovery for most cases was actually not so great. So if you think about them, 14% in the first study, NASR study, had renal recovery, 55% had residual CKD, 32% ESRD, 18% mortality. Go to the next study, similar kind of findings, 12% mortality. Only one that didn't kind of match was this other NASR study of 17 patients where they had 70% had renal recovery. This was a mixed bunch. I think some might have had post-streptococcal GN in here as well. I need to go back and look at that study, but you can see the mortality was minimal in this case. If you look at the Boyle study and you look at the other small retrospective studies, you can see that most of these patients are left with residual CKD. Mortality is there. This one study of 2 patients, both patients passed away from sepsis. So just should give you pause when thinking about steroids and reaching for steroids in this patient population, especially once an infection has been discovered. Now, this is going back to that larger study that I talked about. This is from the group in India and published in CJASN in 2021. So again, 501 patients, they stratified it initially into 3 different groups, but then they looked to see, okay, patients who got steroids versus no steroids, how did they do? Now, remember, this is not a randomized control trial. This was an investigator discretion as to whether they got steroids or not. So you can imagine steroids were given to the more severe cases. And in fact, when you look at the proteinuria level and patients with crescents greater than 50% crescents, certainly more in the steroid group. And the eGFR was lower in the steroid group, and so was the proteinuria was higher in the steroid group here. You can kind of see. But the majority of patients got steroids. 376 patients out of 501 got steroids versus 125 did not get steroids. Ultimately found that there was no difference in outcome. There was more deaths in the steroid group. Remission was similar between the 2 groups. Kidney failure was similar between the 2 groups. So whether that's a nod that steroids actually help things because these were more severe at baseline, or whether that's a statement to say that, hey, steroids didn't help anything and we should maybe be cautious, especially with the increased number of deaths in the steroid group. We should think about it. But the data is limited to observational studies, as mentioned. Randomized studies are lacking. But this basically is this study, along with the other studies, kind of suggests we need to be cautious when considering steroids or other immunosuppressants in this population. What we really need is a randomized control trial, and this was published in 2022. This was a randomized control trial by another India group, a group from India, where they had patients with biopsy-proven infection-related GN. This was single-center, open-label study comparing corticosteroids supportive care alone for patients with infection-related GN and serum creatinine greater than 1.5. So a couple caveats of the study. It was supposed to be a much larger study, but they had to taper the study because of COVID. Ultimately, they had 52 patients that underwent randomization. 26 were assigned to corticosteroids, 26 were assigned to control arm, and they had a few left to follow up. You can see the baseline demographics here across the groups, pretty similar across the groups. Proteinuria was similar, peak serum creatinine was similar, but you can see here is very severe disease. Now, one of the things about this study is the patients had to have completed antibiotic therapy before they were actually given immunosuppressive therapy or corticosteroids. So you had to have completed antibiotic therapy. And the primary outcome was complete remission at 6 months. Exclusions were the most severe cases, patients who had greater than 50% crescents, had bad diabetes, had greater than 40% IFTA in those, or their active infection was going on for greater than 21 days since infection onset. In those cases, they were excluded from this study. And when they find, ultimately, they found no difference in the steroid arm versus a non-steroid arm in terms of renal outcomes, complete response, partial response, death or ESRD was higher in the steroid group. Resolution of proteinuria was similar in the groups. Dialysis dependence was high in both groups. You can see 83 and 90% in both groups. So really no benefit from steroids. And in fact, obviously the complications, infectious complications, side effects from steroids were there and more common in the steroid group versus a non-steroid group. So what can we take from all this? Ultimately, the goal of treatment in infection-related GN is to eradicate the infection, and source control should help preserve kidney health. The sooner we get source control, the better off we'll be. So source control can take time to achieve, especially in deep infections, hidden infections, where diagnosis is often delayed. About 40 to 77% of patients across the observational studies with infection-related GNs has had sustained chronic kidney damage. Approximately 30 to 40% will progress to end-stage kidney disease. The predictors of poor outcomes for infection-related GN include a history of diabetes, presence of diabetic changes on biopsy, so they have some sort of concomitant underlying kidney disease in addition to the infection that's present, history of CKD, and level of interstitial fibrosis, tubular interstitial fibrosis, as typical for other diseases in the advanced stage. So this is an algorithm that we put together on how to kind of think about these cases or evaluate them. So you see a patient who presents with signs of acute glomerulonephritis, and you diagnose them with active staph infection. Have you confirmed it? If you have, and they have acute glomerulonephritis, the likelihood is they have staph-associated GN. At this point, I'd even argue that you may not even need to proceed with biopsy, and you can treat them for suspected staph-associated GN with appropriate antimicrobial therapy based on the source of infection, and you would avoid immunosuppression. If you're not sure if they're negative for staph, you suspect they have an active infection, you got to continue with the further workup. This includes all sorts of cultures, x-rays, echo, CT scans, Panorex, or an x-ray of the teeth to see if they have a dental infection. If you identify the source, you go back to treat. The glomerulonephritis is probably due to the infection, and you want to treat the infection. If you haven't identified the source, still not sure, serologic workup is indicated, then you perform a kidney biopsy. Is a biopsy consistent with staph-associated GN? If it is, go back and look for the source. If not, it's unlikely, and you want to treat accordingly. And then the risk factors are shown here, as I mentioned before. So in conclusion, the incidence of acute post-streptococcal glomerulonephritis, as I started discussing at the beginning of this talk, has been decreasing worldwide. Treatment supportive outcomes are generally very good. Clinical presentation of GN of active infection often shows acute nephritis with severe AKI, nephrotic range proteinuria, and often requires dialysis. Outcomes are variable in those scenarios, and overall, generally not so great. 30 to 40% will progress to end-stage kidney disease. Importantly, patients may present without obvious evidence of infection. So you really have to have an index of suspicion and make sure if you have any suspicion whatsoever that you do a thorough evaluation. Pathologic mimic of other GNs with pathology varying from IgA-like nephropathy to polyimmune GN, high rates of cross-reactivity with autoantibodies. So just because you have positive autoantibodies, that doesn't mean it's an autoimmune disease. Similar to malignancy, infection can be a great mimic. Differentiating infection-related GN from other forms of GN may be challenging. Again, requires thorough history and an index of suspicion. Avoid immunosuppressions at this point. We need better data, but the current evidence does not support using immunosuppressive therapy in infection-related GN, and future efforts should be focused on developing non-invasive techniques for early detection of these bacterial infections so that effective treatment can be started early. And with that, I'm happy to answer any of your questions. Thanks for your time, everyone.
Thanks very much, Samir. That was a wonderful session indeed. A complete eye-opener, in fact, infection-related GN. I think a very interesting topic. I mean, questions, please. Anybody, questions?
Yeah, I see a couple questions in the chat. If it's okay, if I can start by answering some of those. So the first question is: case 1 in many settings is likely to be treated as vasculitis, especially with negative blood culture, and may have poor prognosis due to immunosuppression and failure to treat infection. This is my opinion, maybe part of the reason. 100% agree with that. I think this is the problem. So again, it goes back to awareness. So I think one of the key facts of case 1 is you have to think about age and past medical history, right? So that we treat that as IgA vasculitis, but we also have to remember that IgA vasculitis or vasculitis itself, IgA vasculitis in particular, is pretty rare in middle-aged patients. And especially those who have underlying comorbidities like diabetes. These are the patients, at least, that we are worried about in our hospital setting. And we're saying, okay, I need to be more, I need to think more like this is an infection and I need to go look for the infection, as opposed to, hey, this is HSP, IgA vasculitis. The reality is once you've ruled out infection, if you've sufficiently ruled it out, you've done your thorough evaluation, then you cautiously start steroids and see how they do. But otherwise, I think, at least in some of this is patient factors, history, past medical, all that should come into our decision making when we think about whether this should be IgA vasculitis versus other. Still, the AGN has significant mortality. Could it be new recommendations on high-dose steroids since autoimmune is well ongoing? Yeah, so I think, and I think AGN, I'm not sure if that means infection-associated GN has significant mortality. I think the question of whether we should be considering steroids in the setting of infection-related GN is unclear. I think right now the current evidence does not suggest it helps things. One question I always think of though is, what if you actually treat the infection, get it under control? The patient still probably has active inflammation in their kidney. Could we consider using immunosuppression at that point? And I think that's what that trial from India tried to study, but they just weren't powered well enough to study that. And maybe we'll have bigger trials going forward to help us answer that question. Does this occur with tuberculosis as well? I've not seen this with tuberculosis, not this particular form of glomerular nephritis. I've not seen it with tuberculosis. Of course, you can get interstitial nephritis and things like that with tuberculosis, but I've not seen that. I don't know that it's been reported. Hold on one second. Let me actually go back and see in that one study if it was something that was reported. Sorry. Yeah, I've not seen that reported with tuberculosis itself in the literature that I looked at. If you find anything like that, I'm happy to be corrected. Yeah, I think so. Here, I do stand corrected. There in this table, looking at pathogens with associated glomerular nephritis, this was reported in 2013 by Sami Nasser. They do report some association with Mycobacterium tuberculosis, avium, and leprae. I haven't seen any cases of this. I think this is all in the case report realm, but I guess it's been associated with, as you can see, all the other bacteria that have been associated with it as well. Any other immunosuppression tried for apart from, yeah, so there is a couple of studies you tried cyclophosphamide, and that didn't show any additional benefit, but the data are limited to small observational studies. And then if biopsy suggested infection-related GN and you fail to find a focus in negative culture, would you? Yeah, so that's the question. So if the biopsy showed an infection-related GN and we can't find a focus, so this is when I would lean towards maybe this is truly autoimmune, especially if you feel confident that you've ruled out infection, meaning you've searched and can't find it. I don't know the role of doing empiric antibiotics if you don't have a source, because I don't know which antibiotics you use, frankly. However, I think one thing that could be considered if it showed IgA-C3 and you were and the pathologist was pretty confident that this looks like an infection that's coming from some location, perhaps using MRSA coverage might be helpful, but that study hasn't been done at all. And like I said, to your point, I wouldn't know which one to use in most cases if we haven't identified a source of infection. In those cases where you haven't identified, I usually start empirically with steroids and follow them closely to see if an infection blossoms. Because certainly if they have an underlying infection on steroids, it should blossom. It's not a great way to approach it, but at some point you want to do something. And if you've ruled out infection to the best of your abilities, then cautiously using something like steroids to see if you can suppress the inflammation may be appropriate. What is your approach to crescentic post-streptococcal? Yeah, so post-streptococcal glomerular nephritis, my general approach is supportive. I think in crescentic cases, especially rapidly progressive glomerular nephritis, I wouldn't fault you for using prednisone. I wouldn't do more than prednisone or Solu-Medrol, at least, methylprednisolone. I wouldn't fault you for doing IV steroids and maybe a short course of corticosteroids, especially in the most severe cases. That being said, and largely, I would say that's reasonable because the data are limited. The only trial that we have is from 1981, and it was a small study that showed no difference in outcomes. So I think in the most severe cases, I think it's probably pretty reasonable. And the one thing that it did show in that study, at least, is that you had improvement faster in the patients who received corticosteroids compared to those who received supportive care alone. So in those cases where you're worried about their kidney failure requiring dialysis, et cetera, might not be unreasonable to try a course of corticosteroids. I'm a proponent of methylprednisolone upfront because I think it rapidly attenuates inflammation, but I wouldn't drag out the prednisone course. I would keep it abbreviated. I think those are all the questions in the chat. Are there any other questions I can answer?
Just one last thing is, now this could be an important cause in worsening renal function in a patient who has diabetic kidney disease, isn't it? Because infections are so common in diabetics.
Yeah, yeah,
What is your
absolutely. Yeah, absolutely. And I think one of the poor prognostic factors are those who actually have diabetic kidney disease, who get infection-related GN. They tend to have the worst outcomes. And so I do think that is probably an under-recognized player of patients with diabetic kidney disease who have chronic wounds. For example, you get the foot wounds, osteomyelitis of those wounds, skin infections. When these patients get infection, I think we really need to think about whether their worsening kidney function in those settings might not be due to, or may be due to an underlying infection-related GN. I think a couple other questions have come in. One asked about, does hypertension also increase the risk for poor outcomes similar to DKD? In the setting of infection, hypertension itself has not been shown to be an independent risk factor for infection-related GN, or has not been associated with outcomes in infection-related GN. Hypertension certainly does occur in the setting of infection-related GN. It does worsen in the setting of infection-related GN, but by itself has not been shown to be an independent risk factor. Yeah, so a good question about parasites. I think largely because it just hasn't been reported, but absolutely, I think parasitic diseases can certainly cause their own form of kidney disease. Schistosomiasis is one of those. We don't see a lot of that in the US, but absolutely it should be considered and be on the list of infections that we should be worried about that's causing kidney disease.
So I think if there are no more questions, I think we call it a day. Thank you, Samir. This was a wonderful session. Honestly, I had not really known so much about infection-related GN, and it's really an eye-opener and something really needs to be looked into. And especially in the tropical areas, and especially in patients who have diabetic kidney disease, I think it needs to really be looked into.
Yeah, no, yeah, happy to join and participate today. Thank you again for the invitation. It's always a pleasure to be with you guys and to share. I'm very curious to see what your own experiences are with this as well as time goes on. So feel free to share. I would love to learn more about what's endemic to your own countries, respective countries. And learn more about what you guys are seeing, like you mentioned with the schistosomiasis. I don't see a lot of that, so very curious to see what kind of pathologies you guys are seeing as well.
Thanks very much, Samir. Thanks for the time.